Well, a very pleasant good afternoon and welcome to Let's Talk. Welcome to all of our viewers who are joining us this afternoon on Let's Talk. We will have part three of that very interesting discussion that we started some weeks ago. We are talking about reproductive technologies. We are looking this afternoon specifically at two areas that we did not have time to discuss when we were on with Dr. Brown before. We are going to be talking about surrogate motherhood, and we are going to be talking about tubal ligation reversals. With us this afternoon, again, to discuss on Let's Talk is Dr. Samuel Brown. He, of course, is the Managing Director of Brown Fertility, a series of centers in Florida that concern themselves with making people smile with the gift of childbirth. We are grateful to have Dr. Brown with us. He's a physician of great experience. He has been involved for several years in this technology, and he has given up his time to speak with us this afternoon. Before we welcome him, let us just bow our heads for a word of prayer. Almighty Father and our God, we pray that you will be with us as we go into this afternoon's Let's Talk. We pray for your guidance. Give us understanding and wisdom as we proceed in your precious name. Amen. Amen. So, Dr. Brown, it's a delight to have you on Let's Talk one more time.
Thank you, Dr. Greene.
We are so happy that you are able to facilitate this afternoon's discussion. Welcome back to Let's Talk.
Thank you, Dr. Greene. It's a pleasure to be here.
We are always delighted to have you with us. The last time you were here, we did promise to touch on the areas of surrogates and tubal reversals. We did not quite get a chance to do that, and we are happy that you were able to facilitate us this afternoon. But before we go any further, please explain what is the basic concept behind surrogates.
Got it. It's a good question. So what is surrogacy? What is a surrogate? And by today's standards, we call a surrogate basically a gestational carrier. So the proper medical term is being someone carrying a baby for another woman, or is called a gestational carrier, or it'll be called a gestational surrogate. That'll be kind of changed, altered a little bit. But what that means is, at least in most states in the United States, if a woman has a uterus problem where she cannot use her uterus to develop a pregnancy in her body, we can use her egg and her husband's sperm and place it into another woman's uterus. And that's called gestational surrogacy. For example, a woman may have had a hysterectomy, but she still has her ovaries and she wants a baby. So we can still obtain her eggs with a needle and use her husband's sperm and create embryos outside of the body, and then place them into another woman's uterus, which we call a surrogate, or it's a gestational carrier.
Now you went ahead and answered part of my next question, because I was going to ask you what are the kinds of circumstances that would lead to this procedure taking place. I'm only imagining that, you know, to have somebody agree to go through 9 months of pregnancy for another person is quite an undertaking. Has to be a very good friend or somebody who is being paid a hefty sum for that, I'm assuming. Now, for the person who is carrying the baby, the lady who is given the services, so to speak, now she did not produce the egg. I know generally, under normal circumstances, when a woman ovulates, her body prepares for pregnancy. So is there a particular timing when the implantation has to be done in this mother, or it can be done at random?
It's a great question, Dr. Greene. And to prepare a gestational carrier's uterus or a surrogate uterus to place the intended parent's embryo into her body does have to be prepared. And it's a pretty simple thing in what we do in this area of medicine of reproductive endocrinology, where we kind of turn off her hormones with an anti-hormone. And then we give the woman estrogen, and it could be given in the form of estrogen pills by mouth or estrogen patches on the skin. There's other ways to give estrogen to the body to make the uterine lining thick. But what sets the clock, what's crazy important, is when we have to instruct the surrogate when to start progesterone. And she has to take either progesterone vaginally or in injectable form. But the day that she starts progesterone sets the clock, and exactly 6 days later is when we place 1 or 2 embryos into her uterus. So there's a timing, there's a lot involved with timing, and we do control the hormones. It would be very difficult to do in just a natural cycling woman's uterus, just to put them in on a specific day. We kind of control it a bit. We call it programming the woman's uterus to receive the embryos. But yeah.
Okay, that's pretty interesting. I'm learning a lot here.
Yeah.
And I assume too that this lady has to be healthy, and you would do evaluations to make sure, and I'm assuming that she has to be young enough as well.
It's a good question. And to become a candidate for if the intended parents, husband and wife, need to use a gestational carrier or a surrogate uterus, yes, they have to come in for a physical examination, and we have to ask them questions. And at least in the United States, it's governed by a lot of regulations from the federal government. So we have to go through a list where they can't have infections like HIV or hepatitis. But there's not only a medical clearance that we have to give the surrogate, we also have to have a legal contract. There's attorneys, fertility lawyers have contracts where the intended parents will sign this contract with the surrogate to behave properly when she is pregnant, to go to her doctor visits and to follow. So there's a contract, a legal contract between them. So so she has to mind the directions of the physician, and it's pretty easy to do. But it's also a legal issue where it's not an adoption. So she can't choose to keep the child, at least in the United States. The laws are such where even though adoption laws are a little complicated in every country. And this intended parent contract, legal contract, makes it very clear that the gestational carrier or the surrogate is not allowed to keep the baby.
Now, before we go into that, as you were speaking just now, you indicated that the woman cannot have HIV, etc. And that triggered a question in my mind. On an earlier discussion, when we were talking about artificial insemination. So if a lady who is HIV positive or her husband is HIV positive, I am assuming that there's a danger of either one infecting the other if they want to get a baby. But can they choose to have a child via artificial insemination, where you take the egg and the sperm and fertilize it, and then can that be reimplanted in the woman, and would that be safe for the baby?
It's a good question. It's a little bit off topic, but let's say the intended parents, the husband has HIV and the wife does not. In the United States, the standard is not to do insemination with his sperm, because then she could get infected with HIV. So the standard to keep it healthy, we would normally recommend IVF, where we pull her eggs with a needle, and then with his sperm, we place 1 sperm into 1 egg, and that keeps the virus away from the embryo, even outside the body at this early stage when we're fertilizing eggs. And that removes the white blood cells that would infect the woman. It's the virus is carried in the white blood cells. So by pushing 1 sperm into 1 egg, there's no white blood cells. And then we could put that back into the woman. That is our current standard of care, knowing that there's never been a case where the woman got HIV from that process. So it removed his HIV from infecting her. Now, vice versa, if the woman has HIV, she can be pregnant, and we take care of HIV pregnant women all the time. It's just they have to be on the standard of care is they have to be on some medicines to lower the virus numbers, and they have to have a C-section. They can't have a vaginal delivery, and that prevents the baby from getting HIV when the woman, the mother, carrying mother, actually has HIV.
Okay, yeah, that was definitely off topic, but
Yes. Yes.
you did say something that caused me to think about that. So thank you so much for answering
Sure.
that. Now let's get back to the surrogate issue. You were indicating that there is this contractual, this legal agreement between the carrier and the
Intended parents. Right.
intended parents. Yes. Now, on an earlier program, you indicated that there is some kind of bond that develops between a baby and a mother, the person who is carrying the child,
Yes.
even when the egg does not belong to that person. So I am assuming that that bond can be very strong. And when the baby reaches delivery, there may be some attachment. Now, you indicated that there is a contract where the carrier, I'm assuming, has to sign to say that they are not going to keep this baby.
Correct.
Okay.
That's correct. There's not, at least in the U.S., there's not any fertility centers that would allow them to do this interaction without that legal contract being in place, that intended parent contract with the gestational carrier. That is correct.
Now, does this contract also cover things like contact? So the child may not be mine, but I'm so attached, I want to monitor them, see that they're doing well later on, send gifts for them on their birthdays, etc. Does that contract cover all of that?
It really does. It makes it very clean and very simple and straightforward, where the gestational carrier is performing a service. She's carrying this baby for 9 to 10 months for this couple or this intended parents. And you're right, they can get attached, but they make it very clear where there's no argument that they cannot have the baby, or that the gestational carrier cannot keep the baby, unlike adoption law. And it's going to get into a complexity I'm going to talk about in just a moment. But it doesn't seem to be much of an issue, even though there is this bond, from early pregnancy and growing in the woman. You don't hear of it becoming a problem where the gestational carrier wants to keep the baby. At least in my experience, I've never heard of it become an issue. I've heard of little issues such as where the woman was supposed to report to the OBGYN's office for checkups and examinations monthly, and where she didn't do that. And then they had to get a judge involved to tell her she had to go see the OBGYN every month under contract for the baby's well-being. So I've seen the contract kind of have some bite to it. It's not a simple contract. It covers all these issues, including reimbursement. Like if the couple decides to pay her money, in the United States, it's really a complete arbitrary agreement where the woman carrying the gestational carrier can do this for free, or in Florida, for example, they may charge the couple $25,000 US just to carry the baby for them, and then also that in that contract are the issues associated with delivery, hospital, like who pays for the hospital bill and the obstetrician's bill when they deliver the baby. So the contract has all of this spelled out and makes it very simple and straightforward. Excuse me. Now, there was one last piece. Now, to differentiate this, to make this clear, back in the old days, before the days of IVF, before 1978, back in the old days, they did traditional surrogacy. Traditional surrogacy is when a man and a woman could not conceive. They could not get pregnant. So the wife would be in agreement that the husband would have sexual relations with another woman that was ovulating. So they're using this other woman, this married couple would use this other woman's uterus and egg in the same person. So genetically, it's that other woman, it's that the husband, and then she gets pregnant, has the baby, delivers it, then hands it back over to the intended parents, the husband and wife.
And that was legal?
Well, yes, and every country is different with this, but it's hard to find a doctor in the United States that will help with this process, because there's so many complex laws involved with adoption. Like, this is kind of the point we've been getting at. It makes it so complex with adoption laws that most fertility centers will not engage in such treatment. But back in before IVF, before 1980, that a lot of kings and queens from countries would do this to have a male offspring, or just in general, couples would use traditional surrogacy. But so you don't see much of that, at least in the United States. But it still happens in other countries. I'm certain of it.
Now that sounds to me like adultery.
Right. It's basic to me. Right. Yeah. There's lots of issues with that.
Now, Doc. I wanted to interrupt you a little bit there, because with the surrogate, the way we do it these days, the way it's done these days. Yes. This may seem a little simplified as a question, but when a woman is pregnant, she prepares to feed the baby so that her breasts develops milk, her breast develops milk, this whole lactation process, etc. What happens, this may be true also for other ladies, because there are some women I understand who choose not to breastfeed their babies. But what happens to the milk that is developed, specifically because we're talking about surrogates now. So what happens to all that milk that is developed in her breasts? And does it have any effect on the woman?
So that's a good question. Lactation, so producing milk after delivery. Yes, the woman who is pregnant, her breast will be primed to create milk. But if she does not breastfeed or allow the baby to latch and feed, then the breast will, just like stopping breastfeeding in any other woman, the breast will just stop making milk. And there's tricks to that where they bind the breast, or they use cabbage leaves and things to help dry up the woman's milk for the surrogate. Or there's opportunity where she could pump milk for the couple. She can be used as a wet nurse, or create milk and freeze it for the baby. And actually, medically, even the woman who didn't carry the baby, the intended parents, the woman who gave her egg with her husband's sperm to have this baby, we can use medicines to make her lactate. We can make her produce milk, even though she was not pregnant.
Oh, that's interesting.
Yeah,
I never knew that before.
Yeah,
Wow.
So we can give her medicines to induce her breast to make milk. Yes.
Okay, amazing. Now let's get back to the 9-month period, 10-month period, as the case may be. The activity of the carrier is important. My understanding is that your mood, the things you do, your sleep patterns, etc., can have impact on the developing baby.
Yes.
So how is the woman monitored to ensure that she's fulfilling what, if as a couple, my wife and I decide that we want to employ the services of a carrier, we would want to stipulate that there's some activities that she can be engaged in. I guess all of those would be built into the contract.
Yes.
What kind of monitoring is done to ensure that happens?
That's a good question. And there's not much monitoring in regard to, I agree with you that the thing called epigenetics, where even though this husband and wife hire this or want to use this other woman's uterus, there is an effect from the first day the baby grows up until birth. That woman does have an effect on this baby called epigenetics. And typically there is no follow-up on her mood issues, except, of course it says in the contract she's not allowed to use alcohol or tobacco or and that she has to see her obstetrician gynecologist, her obstetrician regularly. And I guess it would be the role of the obstetrician to see if she was depressed or if she was drug seeking or to find signs or symptoms of bad things. And that could be alerted ultimately to a judge that's presiding over the contract, if there was issues. But otherwise, there's no psychological therapy that I'm aware of or mood therapy that's necessary or is monitored during the pregnancy.
Okay, and after delivery, some mothers get postpartum depression. Does that happen in the case of surrogates?
Sure, it can. So I think with any woman after having a baby, certain women are predisposed or can get postpartum depression. And yes, I think even a gestational carrier or a surrogate, after the hormones crash down, it's a 6-week process for the hormones to stabilize and normalize again. They could get postpartum depression.
Okay, interesting. Now, I mean, I'm marveling at the development of science when you indicate that, you can give the mother medicine to help her, the parent, to help her lactate, etc. That's interesting. Here's my next question. Can a person use a surrogate to carry a donated embryo? You said just now, here is a couple who, for whatever reason, may not be able to carry the baby. And so the mother gives the egg, the husband gives the sperm, and they arrange and contract this carrier. But can we have other cases where, let's just say I'm married and my wife is young and she feels that 9 months of pregnancy is going to be too much stress on her body, and so she's going to use another person. And I'm asking 2 questions in one. That's one. The other one is we can't produce sperm or egg at all, and we get a donated embryo, but we are contracting somebody to be a carrier.
It's a good question. It's a very good question, and it's very interesting answer I'm about to give you. At least in the United States, every state is different on this law. Like, is it okay to use a surrogate? And for example, in Florida, the state law is such that you have to be married, number one. And number two, the doctor has to sign a medical affidavit that it was medically necessary to use somebody else's uterus. So you cannot do it just out of convenience in Florida. You have to have some type of medical reason. For example, if the woman has a seizure disorder and she doesn't want to come off her seizure medications because those medicines are bad on the baby when it grows in her. So that would be a medical reason to not be pregnant. So by Florida law, you have to be married, legally married, and number two, you have to have medical necessity. Where in places like California, it's not true. You can do it out of convenience. If you're a rich and famous actress and you don't want to be pregnant for 10 months, you can hire somebody to carry your baby for you. But oddly enough, in other states like Oregon or Illinois, it's illegal to use a surrogate at all. It's considered a felony if you enter into a contract with a gestational carrier in Oregon and Illinois. So state by state is very different on this, and I'm sure every country is different with this.
Now that's interesting, because if I live in Illinois, can I go to California and do that and then come back to Illinois?
Well, it all depends where the baby is born. At least by American laws, like the Department of Vital Statistics, and when they create a birth certificate, it's wherever the baby is born. And we do have that issue. Like in Florida, intended parents will enter a contract, and everything's, they were legally married and they could show medical necessity. But then the woman that was the surrogate that was going to deliver in Florida moves to California, where it's a different law. So then it makes it very hard on so they almost have to build it into the intended parent contract on where they're going to deliver the baby.
Okay, interesting. Very complicated.
It gets complicated.
Wow. Now, Doc. This is a very interesting topic, but I do want to switch because I do want to get to tubal reversals.
Yes.
And I don't want the time to expire because we also do want to give attention to
Sure.
Questions that our viewers may have.
Yes.
In fact, just before I switch, permit me to ask one question.
Sure.
Somebody wants to know if there is a black market. I guess you partially answered this just now, but I'll still ask the question anyway. If there's a black market of surrogacy, and are there regulations in place to deter it?
I've never heard of illegal activity or black market activity with surrogacy or gestational carriers. And part of, at least in the United States and most Western medical doctors, we also have these couples have to have psychological evaluation. So they do meet, not only will the gestational carrier, the surrogate, or the intended parents have to meet with a psychologist that has to provide the physician certification that they're able to, that they want to do this because they want to have a family. And what they're screening for is consenting ability. And they're also screening for illegal activity. Like, are they wanting to have this baby so they can harvest organs in a different country? So the psychologists that provide a report to the physician kind of probe for those things. So that's where we would worry black market wise, is for organs for other babies in other countries, and for organ transplant. So our system's pretty good legally and psychologically and medically to help prevent. I haven't seen really any black market activity. The only interesting activity we'll find is we'll have couples from other countries come and use a gestational carrier in the United States because they know that just by being born here, the child becomes a citizen of the United States. So you do see couples doing this process from other countries, possibly just to get citizenship in the U.S.
Okay, interesting.
Yeah.
Here's another quick question. I'm trying to cover the questions here before we move on to the next topic. But this person is asking, how safe is it for women doing induced lactation, surrogacy, and are there side effects?
It's a good question. It just takes a few medications, a dopamine agonist medication. There's a few other medicines we use that will induce lactation. It's pretty safe. These drugs are used in from a psychiatrist typically, but we can write for them as an infertility specialist. We can write for these medications for the woman to take. And it allows the brain to send the signal to the breast to make milk. It's very safe. There's not a whole lot of side effects, and it's actually pretty affordable drugs. The medications are not that expensive to induce lactation.
Oh, interesting.
It's pretty easy to do.
Yeah. All right. And last question before we move on. This is an interesting question. What does the judge do if she drinks alcohol? We were talking about the contract, and that the carrier is not supposed to use alcohol. So this person wants to know, if the person does use alcohol, and there's a court case, what does the judge do?
Good question. I've probably done most of this. I've done more of these type of cases than anybody in Florida. We have a lot of patients that fly to us from Brazil where using a gestational carrier is illegal. So we have a lot of Brazilians that fly here and use gestational carriers. And also French. We have a lot of French citizens that will fly to, Europeans will come to Florida where it's illegal in their country to use gestational surrogacy. And we'll help them have a baby here. And then within 2 weeks, they can have their baby back home. And it works out very, very well with American laws. Now, I'm sorry, the point of your question was...
What does the judge do if they drink alcohol?
Well, I've only seen one situation go awry. I know the lawyers that do all of these, and I've only seen one situation where the woman wasn't going to her obstetrician, and the judge was going to incarcerate her, so to force her to see her obstetrician once a month.
Oh.
So they when it comes to the baby's health, the harm of the child, at least by American laws, it's the judges and the legal system will come down on the culprits very viciously. So the well-being of this unborn child is a very, very serious thing to American judges. So now, for example, now I've seen the judge threaten to incarcerate this woman to make sure she would go to her OB appointments. But there can be things in that contract where she can be drug screened or alcohol screened randomly. You could put in that contract that she's screened for alcohol once a week and she has to report to the OBGYN's office to have it done. So there's all kind. You can tailor this any way to make the intended parents feel comfortable.
Okay.
It's all in the contract.
Now let's switch to
Sure.
tubal reversals. I'm aware that your specialty is in the area of helping persons to get children. Last week we had a discussion on contraceptives, and it was said that couples have the option of taking permanent measures not to have children. For the benefit of those who may be listening for the first time, what are these permanent measures? Or should I say, in your case, so-called permanent measures, because you.
So tubal sterilization techniques. That's what you're asking about.
Yes.
Yeah. Currently, there's two main ways to tie a woman's tubes or to render what we call, it's considered, they call it permanent sterilization. And one way is at a cesarean section. If the woman signs consent forms before the delivery, she can have her tubes tied at her cesarean section. They just take a middle portion of the tube, and then the tubes heal and separate, and it's 99% effective. It's very, very good. They do both tubes. And then now there's one called interval sterilization where more than 6 weeks after delivery, a woman can have a laparoscopy where we put a telescope in through the belly button and go down to the fallopian tubes and then either apply clips or to the center of the fallopian tube to separate the tube, to kill a portion of the middle of the tube, or put a ring that causes a couple centimeters of the tube to die, and then it will separate also. So you can do it laparoscopically that way. Those are what we call irreversible sterilization techniques. So those women do routinely come seeking advice, wanting to have a tubal reversal. There's a lot of I don't know the exact number in mind, but there's a large percentage of women that have permanent sterilization that have regret. And I can't remember the exact number. I'm going to guess 10, 20% of women that after 5 years of having their sterilization, they wish they had not done so.
So before this procedure is done, I'm not talking about the reversal. I'm talking about the decision to do the sterilization in the first instance.
Okay.
Before it is done, what kind of counseling do you give the woman to say, hey, listen, are you sure you want to do this? And so talk a little bit about that.
Yeah. In the United States, it's pretty aggressive. You know, I'm a fertility doctor, so I don't do that anymore, but I was trained to do that. And general OBGYN doctors will give counseling before they deliver, or just in general, if the woman meets the gynecologist and wants to talk about permanent sterilization, they're pretty aggressive. There's a lot of laws in place where it's not so easy. They kind of have to tell them it's permanent. And they even tell them that there's a 20% chance that women wish they had not done this, and that they would, and it may not be able to be reversed. They make them sign legal consent forms that they've been informed of all these bad things that can happen from a permanent sterilization. So now, 30 years ago, it was really easy. If the woman said, "Hey, just tie my tubes," then they would just tie her tubes. But by today's standards, it's a little more aggressive. There's special consent form process and documentation, but they don't make them see a psychologist about it. To see if they're properly of consenting ability. They don't do things like that.
Are there cases where this is forced, where they do it against the woman's will?
It's a good question. I don't believe that exists anymore. I think that's in the United States that like for mentally handicapped females in the old days, they used to do that. They would sterilize them to prevent unwanted pregnancy. but I think they could, like in mentally handicapped females, with proper consenting, they can have their tubes tied. You know, the consenting parents or whoever. But you don't hear of this very often. This is a pretty rare thing. I've never, in my experience, in my career, I've never heard of someone having their tubes sterilized or tied against their will.
And is there any law that says if you're a certain age, this can be done?
It's a good question. I don't know the answer fully, and I don't know if that's a state-to-state thing. It might be a state-to-state law, but I know the woman has to be at least 21 years of age pretty much to get her tubes tied. I think that might be a legal issue. Under 21, it might be very difficult. Even if the woman's had 4 children under age 21, 21 might be the legal age minimum necessary for consenting.
Do you have cases where women tie even if they have no children?
Yes, we do. Not very often. At least from my experience in Florida, we'll see more gentlemen that will have a vasectomy in this case, where they've never had children, didn't want to have children, and they chose permanent sterilization with a vasectomy. But I've never heard of it in a female. Maybe one patient out of thousands and thousands. I have heard of it, but it's very rare, where somebody will just want to have that form of contraception and never have had a child.
Okay, now I don't know how prostitution works in the United States. I'm not sure if it's legal or illegal, but I do know I've heard, I've watched documentaries of ladies who are into prostitution as a career, and would a prostitute, for example, a female prostitute, decide, listen, let me do this just in case because I don't want to have a child?
So yes, they could. I think legally, of consenting age woman can have her tubes tied at any age, and if she even professed or was clear to the doctor that she was a prostitute, she could have her tubes tied, and then later in life she could potentially have them reversed.
Now, before we talk about the reversal, what is more common, to your knowledge, for a woman to take the permanent measure or a man?
It's a good question. I'm pretty sure it's more common for the female. I don't know the numbers exactly, but it's very, very popular in the United States to do both. Tubal ligation is still it's probably in the top 20 of all surgeries in the United States. And a vasectomy for the man I don't know the number on this, but my suspicion is it's probably almost even, or probably more common for the female to sterilize, but both are pretty popular, very popular forms of contraception, permanent contraception.
Okay, so when a person takes a permanent measure, whether it be male or female, what happens to the eggs or the sperm?
It's a good question. Now, it's different for the man and the woman. This is what most people don't know. This is very interesting science. For the woman, when she ties her tubes, she can reverse them at any age, up to age 50 or 45. But the problem is for a woman, after age 42, 44, her eggs, usually, we know 99.9% of women will not get pregnant with their own eggs after age 44. So 44 is the end of the road. And we're educated to really not reverse a woman's tubes after age 40, because she just won't. The odds of getting pregnant after 40, 42 are pretty bad, because the egg quality really gets very poor after 40, 42. So the cutoff for most infertility doctors is somewhere around the age 40 that they would not reverse her tubes. For a man, if he's had a vasectomy, he can have a vasectomy reversal, but it's very time sensitive. Most people don't know this point. It's kind of strange. There's interesting science behind this, but if a man has a vasectomy, he only has 7 years to reverse it. After 7 years, it doesn't reverse well because the body attacks that juncture and scars it in, so it fails. So it's kind of an interesting science where when you have a vasectomy, it exposes the man's immunological system to sperm for the first time, because normally the immune system can't see sperm, it's protected. But once you have a vasectomy, then the body sees it, the immune system sees it, and it creates antibodies, and almost like a vaccine. It's like vaccinated to sperm. And then, but for the weird number is 7. After 7 years from the vasectomy, they do not reverse well. They want to scar in. So with those gentlemen, we go to their testicles with a little needle and get all the sperm we need for her IVF process. Just a minute amount of sperm can easily be obtained without a reversal after 7 years from vasectomy. And we can use that sperm with her eggs from the IVF process, and they do very well. We do a lot of that.
Now that is again very interesting. So men need to be counseled before they take this procedure. The natural thing is that sperm is released on a regular basis.
Yes.
No, so if there is the vasectomy and there is no outlet for it to be released, yes, what happens? Does that affect the man?
It does not affect the man. And somehow, some way, I think sperm will eventually break down. Like if it comes to a dead end where there's an obstruction, sperm is always continuing to be made, and it goes down a path. And when it comes to a blockage, eventually it breaks down into little pieces and it gets absorbed into the body somehow. So it doesn't build up, it doesn't hurt the man, it doesn't break the machine, it doesn't backlog and hurt the testicle. There's no negative on the end organ. There's no negative in regard to having a vasectomy. Correct.
Now let's talk about the reversal itself. I mean, you have done several reversals. Why would someone want to do a reversal? And is it common? Do you have lots of folks come in to say, listen, I'm sorry, I made a mistake. Please do something about this?
That's a great question. I'm glad you're bringing this up. And we're I think the only center in Florida that still does tubal reversals for women. A urologist would reverse a man's vasectomy, but they don't educate them that it's not good after 7 years from having the vasectomy performed. But for a woman, we're the only group left in Florida. I believe there's maybe one other group in Sarasota, Florida, that still does tubal reversals like we do. And yes, those patients are desperate for that form of treatment, and they seek us out and they find us. And there's I'd say it's probably 5% of our practice, maybe 10% at most, women that had tubal reversals and had tubal ligations and would like a tubal reversal. Now we still, most fertility centers, they don't like the challenge of surgery or the inefficiency of using the operating room. They would rather the patient just go straight to IVF. So most fertility centers would talk them out of a female out of a tubal reversal and try to just talk them into IVF. But no, it still exists. And there's women that would like tubal reversals, especially those where the husband died and she remarries and she wants to have more than one more child and she's still young enough. I think tubal reversal is a wonderful option, especially if she wants more than one child. But because then she can have that one procedure and have 2 or 3 more children depending on her age. So I think it's more cost effective to have the tubal reversal in certain circumstances.
If you may, Doc, I don't know at all, but it sounds to me like this is a pretty complicated process. What's involved?
Well, the only thing with tubal reversal, it's not very complicated. It's more of a financial thing.
Oh.
It's for the physician, we don't charge much to do it. As a surgeon, when we take the patient to the hospital, but the hospital is very, very expensive. For example, we might charge $5,000 to do a tubal reversal, but the hospital, to use their equipment, they could charge $30,000 to use their robot machine or to use their fancy hospital. And some of us will also have a situation where we'll negotiate a contract with a smaller surgery center where we can do a little C-section cut and then bring the uterus up, fix the tubes, put it back. And it can be as low as $5,000 or $7,000. So it's really a financial thing with the hospital or the surgery center, and where can we get it done cheaply or more affordably? Our portion as a physician, we don't get paid a whole lot for the procedure, but we're very aware of how expensive the hospital can be.
Okay, and after the reversal, is the woman at home for a week or 2 weeks, or?
Well, it's a good question, and the way I like to do it is if she has a fibroid or has some concomitant disease, like if she has endometriosis or adhesions or some fibroids, and we have some other reason to take her to the hospital, then the hospital will pay the bill typically because there's other medical necessary procedures necessary. And then I like to go in with tiny instruments where we use minimally invasive surgery we call it the robot or Da Vinci robot, where we can go in with tiny instruments and it takes us 2 hours to fix her tubes and also take out a fibroid or maybe take out some endometriosis or something else. The patient goes home the same day just with 3 little incisions near her belly button. She goes home the same day. We ask them to not have intercourse for 10 to 12 days, and then she could literally get pregnant the very next month. She's usually back to work after just 3 days, 3 or 4 days. Like if we do the surgery on a Friday, she's typically back to work on Tuesday.
Oh, okay, that's quick.
Now, the other way, when you do the C-section cut or what we call mini laparotomy at the surgery centers, where you can get it done, like if there's no other concomitant disease and you only are doing a tubal reversal, it's still the same. The patient's back to work pretty quick. It's not a big incision at all. It's a very small incision above the pubic bone. And the woman can be back to work within a week or 2 weeks pretty easy.
Okay, so what I'm getting here is that for individuals who are making decisions with respect to sterilization, they need to understand that should somewhere down the road they change their mind, it's going to cost them.
Absolutely. And just in general, that's a great point. I'm glad you're educating your audience to this. And it is easy to do a tubal ligation or a vasectomy, but the reversing, it's not guaranteed. Sometimes we go in and we can't reverse them. So the big push from the American Society for Reproductive Medicine is what we call LARC, or long-acting reversible contraception, or like an IUD is very safe. And you can remove an IUD and the woman get pregnant the next month. So there's a push for, and when you put an IUD in the woman's uterus, it can be good for 10 years. And then when she doesn't want to get pregnant, they just pull it right out. It's really simple. So that's called LARC, L-A-R-C, or long-acting reversible contraception. And the most popular one in that category is an IUD, which is very safe these days.
But because I was just going to say that I used to hear at one time that they were not safe, that a woman who's exercising, it can shift and cause unwanted pregnancies.
Yes. That's good. It does have a bad name. It has a black eye. Where back in the 1970s, there was the Lippy's loop, and there was a few other manufactured IUDs that were really, they didn't know what they were doing back then when they were creating these, and it caused infection and caused problems. And they were sued aggressively. You know, the legal system really turned on them. So I promise you, the ones that are out now are very safe.
Oh, okay.
They're very little. They're nothing like the old 1970s IUDs at all.
Okay, interesting. Now we're going to have a question or two at this point.
Sure.
There are a few questions that have come in. Let's get to them now. Let's see what this one says. Okay, did I deal with that one? Okay, I got that one. This one, is it dangerous for a woman to tie her tube?
It's a good question. It's actually a very good question. There's a lot of science behind that. I mean, is there danger in tying a tube? Well, and there's some basic risks. You know, if you the woman has to go under anesthesia at a hospital typically, or outpatient surgery center, and I think that the anesthesia risk, just by putting a woman to sleep, I think it's 1 in a million chance of death just from the medicines they use to put you to sleep. And outside of that, once they go in to tie the tube, the risk could be bleeding, that they actually accidentally touch an adjacent structure like an artery or a vein, and the woman has really bad bleeding and they have to open her up quickly to try to fix that, but it could lead to death. Those are pretty rare events. And millions of these are done every year, but those are pretty rare, but they do happen. When you do millions and millions of these things, you see everything, I suppose. But the one risk that we really have to explain with tubal ligation is failure rate, where there's about a 1%. I think the board certified answer is either 1 or 2% chance that those cut ends will somehow reattach spontaneously. It's amazing how that happens, but I do believe it, where the end is cut and there was a clip or whatever, and the tube somehow will reattach. So then they accidentally get pregnant 6 months later because the tubal ligation did not work properly. It failed. But 98% of the time it is effective.
That's interesting. That's very interesting.
It really is.
What I was taught, and this may be archaic, but I was taught at one time they used to simply tie the tubes. Now they cut and tie. Now you're talking about separating the tubes altogether, and you're saying that they can find their way back together, although it's rare.
What's interesting is when they do a tubal ligation, if this is a tube, they kind of knuckle the tube up and they'll tie a loop around it, and that top loop dies and falls off. And then when that stitch dissolves, the ends of the tube separate.
Okay.
So the goal is they need to be tied, you have to have separation. So, and I think there's situations when they make that loop and they tie it, and then the tubes don't separate, and then the stitch dissolves, and somehow the mucosa wants to find mucosa, and the tubes it won't be ligated anymore. The body's amazing this way.
Indeed, it really is.
It really is.
I mean, it was made to function a certain way. So that's really amazing.
Really
a follow-up question to that one is, what is the success rate? You may have answered this. What is the success rate for reversal of tubal ligations?
Yes, I think the board certified answer is that at least 80% of the time, at least one tube will remain patent, will remain open. If you're able to reverse 2 tubes, then after the healing process, the board certified answer is only 20% of the time that both tubes will scar back in. We see less than a 5% failure rate. We have actually less than a 2% failure rate. And I think it could be the skill of the technician doing it, the surgeon. Have they done a lot? Have they not? Could it just be the woman's anatomy where she had endometriosis and fibroids? There's a lot of things that can kind of boil into that. But we consider it very successful. Most textbooks would quote 80 to 90% of the time, at least one tube will remain patent. But there's a second part to that answer. It can take up to 2 years to start normalizing a pregnancy rate of 20% per month. That's the normal natural pregnancy rate per month is 25%.
Oh.
It's you'd think it'd be much higher than that, but it's not. So with an undiseased woman, the normal pregnancy rate per month is 25%. Of course, I tell my daughter it's 100% every month. but it's amazing how it's really 25%.
Oh,
but within
wow.
a few months, but within a 2, 3, 4 months of unprotected intercourse, the healthy woman is usually pregnant.
There are some, this may be off course again, but just quickly. Some women are more fertile than others.
Yeah, I believe that. I have I can't answer that scientifically. I don't think we have good data to support that one ethnic group is more fertile than another ethnic group, or so I don't think we can say one woman is more fertile than another, but if she has diseases, she's going to be less fertile. If she has endometriosis or pelvic adhesions or a history of a sexually transmitted disease, she's going to have less. But I don't think you can prove one woman is more fertile than another one if they've had no health concerns during their lifetime. I don't think there's any ethnic differences.
Here is an interesting question. One of our viewers, I missed it. Here, where is it now? If your testicles are accidentally severed can they be frozen and have sperms extracted from them later?
So if the testicles are severed, but they remain in the scrotum, yes, you can get sperm from those testicles later. As long as they're not dead, they have to have at least a nerve or blood supply. Now, if they're dead, where they have no nerve or blood supply, then no, then and they remain in the scrotum. So it just depends on the scenario.
But how long would it take if let's say a man gets in an accident?
Yes.
And his wife, I don't suppose she'll be thinking about this, but just for the sake of argument, she says, listen, we don't have a child yet. I want a child. Can you quickly extract some sperm so that I can do
we get this. It's a very good question, and it's very controversial. We get a call once a year for this. And here in Florida, there's a famous beach called Daytona Beach, and they have a motorcycle festival there. And thousands of motorcycle riders will come to Daytona, and there's always a few deaths from motorcycle accidents. And we get the call. We get the call about once a year or once every other year. They'll call and say, "Hey, my husband's dead. He's brain dead. He's on the ventilator at Advent Health in Daytona Beach. Can you extract sperm from his testicles? Because we want to have children from his sperm." That's your question. And now it gets very, very complicated. It enters an area of medicine called posthumous reproduction. So he's not of consenting ability because his brain is dead. And most of the time we will not do it unless it was in his will or there is something showing his consent for this. In certain states like Massachusetts, it's even more complicated. I believe it's illegal in Massachusetts after the gentleman's declared brain dead.
What is the difference between that and you take some sperm from me and freeze it, and then I die, and the woman decides she wants to have a baby with those sperms?
Well, most of us, I'd say 99% of fertility centers, we have you sign a consent form, and why are you freezing that sperm, and you're giving, you disposition that in case of death. We make you sign a consent form that if you were to die, do we have to discard it, or does your wife have ownership? And most of the time, they'll allow the wife to have ownership, and then she can use the sperm as she would like.
Okay. Another question, Doc. What about DNA fragmentation?
Yeah.
Can it be cured?
Yes. So the question is probably coming from someone that has a bad sperm count, and they did a sperm test, and there's this fancy test you can get called sperm fragmentation assay. And it's for gentlemen that have low sperm counts. Yeah, you expect a lot of their DNA to have fragmentation, but it's not a standard test. It's not one, it's not by standard of care. If a gentleman has a bad sperm count, we do not have to do that test. And in my heart, I don't believe in it. It's been around for 20 years, and I don't think that's the answer. I think if you have live sperm, you can have a baby. If you, maybe with IVF or what have you, you only need a few sperm. But I don't think that, first of all, if you do have sperm fragmentation that's abnormal from that test, which I don't really believe in completely, if you do have that, there's no real good treatment for it. We don't know, like, can we give you vitamins like vitamin C or CoQ10, or there's no science behind it. So it's one of those quasi things that we have to deal with all the time. It's not the standard of care. We don't test for it, but if you do test for it and it's abnormal, what do you do about it? I usually say I don't believe in the test. I don't think it's a good test.
Okay. Well, Doc, this is where we're going to stay for today. I want to thank you so much. We can talk all afternoon, but our time is up. It's just amazing, the advances in medical technology. And for all of our viewers, of course, there are ethical issues involved in some of these things. By the way, the Seventh Adventist Church has guidelines regarding this whole concept of reproductive technologies. Generally speaking, of course, we like to say safely, the husband and wife. We speak about marriage as as a starting point for this. And I'd like to say that that's a decision that has to be made without coercion between husband and wife. We are truly thankful for the wealth of knowledge, Doc, that you have shared with us. And I know that several persons have called personally to ask for contact information for Brown Fertility. So again, if you can just share your contact information, somebody may want to get in touch with you for some reason. Maybe there's a young lady who did a sterilization procedure and she's now regretting it. So if you can give your contact one more time, so
Sure.
that folks can have it.
It's our privilege to be on the show, Dr. Greene. Thank you for inviting us, and we're always available in the future. But yeah, my name's Dr. Samuel Brown. We're at brownfertility.com. Our number is in the United States is 904-260-0352, 904-260-0352 in the United States. We can do telemedicine consultations or phone consultations. We deal with patients from around the world. We're from Brazil, all through the Caribbean, Europe, and China. And we're blessed. We follow Christian principles. We are a Christian-based group, and we believe in life and family. And it would be our privilege to help you and your viewers get their family.
Okay, thank you so much, Doc. For those of you who want to get that information, I hope you did get it. Next week on Let's Talk, we're going to be talking, we're going to be having part 2 of legal issues in the Christian. And then the following week, which is going to be December 12, we are going to be talking about this all-important subject of the moral fall of the pastor. Should he be forgiven? Should she be forgiven? So that's just on the lineup for Let's Talk. We are delighted that you joined us. That's all for today. God bless you and do have a wonderful rest of the day.